Good morning, everyone. Welcome all of you joining the public presentation organized by the Occupational Health Center. Today, the topic is about the Delta variant and the COVID-19 vaccines, presented by the Dr. Pierre Plourde, the medical officer of the health and for the Winnipeg Regional Health Authorities, and the professor for the community health science at the University of Manitoba, the College of Medicine. We would like to begin to acknowledge that we are on the Treaty 1 territories, the traditional territories of the Anishinaabe, Greek, OG Greek, Dakotas, and Diné peoples, and the homelands of Métis nations. We respect the treaties that we were made on these territories and acknowledge that we are all treaty people at the Occupational Health Center. We commit ourselves to a process of reconciliation with Indigenous communities. For the audience participation and follow-up, we would like to ask you to put the question in the chat section on the right side of your screen. The presenter will try to answer it after the presentation at the Q&A. Since we have more than 400 people registered for this webinar, so we may not be able to capture all the comments and the questions. So if you don't mind to connect with us afterwards to follow up, that would be really appreciated. And this session is being recorded for viewing after and share on the social media. And please also participate in the follow-up evaluation survey, giving us some feedbacks for upcoming events. So we would like to telling you about the Occupational Health Center. We are now located on 167 Sherbrooke Street, Winnipeg, Manitoba. We are the community health center funded by the Winnipeg Regional Health Authorities. We provide the services to the Manitoba workers with work-related health issues and work closely with the Joint Workplace Health and Safety Committee for training. Would you please visit our website for more information and the resources? We put the link on the chat. So now please join me the time to welcome Dr. Plourde.
Thank you for that introduction. I will just share my slides here and just get you to acknowledge that you're able to see my presentation. Everything look okay, Tiffany?
Yes, really good, thanks.
Good, okay, thank you. I'll just add to your acknowledgement, and thank you for that, the land acknowledgement, that I have a glass of water here that I may be sipping from occasionally, and it originates from Shoal Lake. We often take it for granted that we can just drink our water out of the tap like this. And the community had to suffer for decades for us to get this potable water. And thankfully now, Shoal Lake Band 40 is able to also share in the blessing of potable water, but it sure took a long time to get there. A COVID vaccine update is what I thought I was doing today. And then I got all kinds of requests to talk about the Delta variant as well. And so I had to completely change my presentation. So I will focus my presentation on vaccines, but I will also talk about vaccines as they relate to variant strains. And as you'll see shortly, especially the Delta variant, because that's the one that's most important right now. So let me show you what's happening in Manitoba. It's not good news. We had a good summer, thankfully, with very low rates of cases, no more than maybe 40 to 50 cases a day throughout the whole summer, sometimes as low as 30 cases a day reported for the province. And this is like barely a week ago where we were still seeing that 30 to 40 cases a day in the province. This is September 20th numbers, and then September 24th, 60, September 27th, 93. And over the weekend, we actually had 2 days with over 100 cases each day. So as Dr. Brent Rusin said in the media yesterday, we are now entering the fourth wave of this pandemic. And we don't know where the fourth wave is going to go. But as we're watching Alberta and Saskatchewan, we are very nervous about where the fourth wave can go, because we see what it can do in our neighboring provinces to the west of us. And this is what we know right now of variants of concern that are most worrisome to us. These ones that have now been labeled with Greek letters to hopefully maybe make it a little easier to identify these strains, because it was hard to remember B117, B16172. Like, it's just too hard to remember that. So what we now know as the alpha strain is the first variant strain that really concerned us, that arose in the United Kingdom, following shortly after a South African strain had arisen in 2020, which is now called the beta strain. And then a strain that came out of Brazil, which hasn't caused much problems yet, is known as the gamma strain. And the strain that is really worrisome is this particular B1617.2. There are different 617s, but the one that's 0.2 is the Delta strain coming out of India, and it is causing significant concern. You'll see why shortly. First of all, in the United States, the Delta strain has become the only strain, practically speaking. Going back to June, where the Delta strain began to be seen here on the orange bar, it was not quite as common as the Alpha strain. This is the strain from the UK here. The Alpha strain was predominating prior to June 2021. And then the Delta strain arose and arrived from India originally. And as you can see, has become the predominant strain, such that 98% of or more of all the strains right now being isolated in the US, which is why the US is having such huge outbreaks and problems with COVID right now, is because it's all the Delta strain. We don't have all the data from Saskatchewan and Alberta, but I would not be surprised if over 90% of the strains in Saskatchewan and Alberta right now are the Delta strain. So what about Manitoba? Well, as of fairly recently, September 24th, of the strains that have been typed, so notice this large unspecified from Winnipeg and other health regions of strains we haven't typed, and we're not sure 100% what variants they are, but of the strains that we have been able to type, the majority of them are this B117, that's the alpha strain from the UK. So far still, most of our variant strains in the province are from the UK, with the Delta strain in the green bar here being a minority of strains in Manitoba right now. But I can guarantee you that as soon as that changes, as soon as the Delta strain takes over, it's going to become the predominant strain, and it's going to spread like wildfire, much faster, say, than the Alpha strain from the UK has spread. And we know this from what we're seeing in other jurisdictions, the United States, probably Alberta, Saskatchewan is all Delta strain activity, but we also know this from modeling that the Public Health Agency of Canada did on the Delta strain. This was modeling done last spring in June, I believe, where they looked at, here's what would happen without the Delta strain, with the usual Alpha strain and other variant COVID strains. We were expecting this fourth wave, this fall and winter, which is right down here at the end of this shaded area, to be a very flattened curve with high vaccination rates as well as public health measures in place. And our hospital capacity would not exceed kind of what's happening right now in Alberta and Saskatchewan, that number of just over 30 per 100,000 people hospitalized. Once you reach that, you overwhelm the healthcare system. But with the Delta strain predominating, this is what happens. We're predicting a significant wave. At the time, they were predicting January, but it looks like it's happening right now in Alberta and Saskatchewan, and it may be starting to happen with us and may peak for us in October or November. And the chances of us exceeding our hospital capacity could again happen sometime in late October or in November if the Delta strain spreads out of control, because it's almost 2 times more spreadable or transmissible than all the other strains of COVID, and it's almost 2 times more virulent, more dangerous, causing more likelihood of people ending up in hospital and in intensive care units. So the Delta strain is going to crush our healthcare system even worse than what we saw in our waves 2 and 3. So despite that, we're still at a provincial response level of caution. We may go back up to red in the next few weeks. It will depend, and we may have to close down again certain activities and increase public health orders. It will all depend on, what happens with the fourth wave. But for now, we know community spread of COVID is happening. Most of that increased activity in Manitoba, half of all those 100 cases a day we saw over the weekend were from the southern health region in the province, where the vaccine rates are the lowest in the province, and maybe the adherence and the practicing of public health measures may also be the lowest, mask usage, for example. And so we're seeing a consequence of that spread is happening much more quickly in the southern regions, but it's going to catch up also in other regions over time. I'm just showing this as I've shown in previous presentations. You can get everything I'm talking about today is really on the province of Manitoba website, where you can obtain general COVID information, or shared health website where you can obtain information as well. But you have to be checking this information constantly, because things change quickly and often, and recommendations can be changing on a weekly basis, if not even daily at times. But regardless of public health orders, and right now there are public health orders for us to be masking, especially and physical distancing in indoor spaces where we are unable, to practice appropriate physical distancing in many indoor spaces that are crowded or potentially so. We are required to mask, and regardless of where public health orders are going to be over this fall and winter, I think we will continue to be recommending frequent hand hygiene, staying home if you're ill. That's the most important one. People have had a whole lifetime of being used to showing up for school, showing up for work when you have a runny nose or when you have a mild cough and are not feeling that sick. That's an absolute no-no. And I know some of us are in jobs where we can't miss work because we don't have paid sick leave. That's a big problem, because then the incentive for you to stay home while you're feeling mildly ill is not there. But if you go to work mildly ill and you have COVID-19, you could actually be spreading the Delta variant very, very easily, even if you're mildly ill. Again, all of these important guidelines: practicing good cough hygiene, limiting your close contacts as much as possible, especially if you're feeling ill, and avoiding non-essential travel as well. We have immunized with 2 doses now, about 80%, but that's 80% of eligible Manitobans. That's really important. Of all Manitobans, because we can't immunize yet anybody under the age of 12. So of all Manitobans, we've only immunized about 69%, 69 to 70% of everybody with 2 doses. So that's far less than what we need to achieve herd immunity. Nevertheless, we've achieved 80% of eligible Manitobans with 2 doses. And hopefully once we get the vaccine approved for younger children 5 to 11 years old, we will achieve 80% or more immunization in that group as well, allowing us to hopefully achieve herd immunity by the middle of winter. We're talking about accessing vaccine and starting vaccinating children, probably not until December at the earliest, for those of you who are wondering. But here's the importance that vaccination makes. The same curve I showed you earlier. So this is what the Delta variant will do, is probably doing right now in Saskatchewan and Alberta, and will probably do in Manitoba if we let our guard down. If Delta becomes the predominant strain in Manitoba, it's going to spread to the point of overwhelming our healthcare system. Even if we have a vaccine acceptance rate of 79%. Now, I don't know if this modeling was done in 79% of the total population or in 79% of the 12 years and older. It looks like 12 years and older. So this is only 79%, where we are now, actually. We're about there now at about 80% of our eligible population. That's not good enough to stop the Delta strain. The Delta strain will still spread and will still make unvaccinated, that 20% of unvaccinated people many of them will get very sick and end up in hospital. But if we have a eligible population vaccinated up to 83%, so we're only talking about 4% more than what is shown in this first curve, we will flatten the curve significantly. Now, this is all theoretical, but according to the models, we only need a little bit higher vaccination rates, about 3 to 4% more of the population being vaccinated. And there are about 8%, 10% people out there who are still undecided, who are not anti-vaxxers, who are not against the vaccine. They're just not sure. And if they are to get, and were to get vaccinated in the next month or so, we would probably make a significant dent on flattening the Delta wave that may be very much coming our way. And, people are wondering, what's the chances that I will encounter the COVID virus? Experts are now telling us, and the epidemiologists are telling us, that every single one of us will be exposed to this virus before the end of the pandemic. When will that be? We're talking sometime late in 2023, probably, or 2022, 2023, before this pandemic is finally this virus is finally behind us and us not having to worry about it. We still have a long way to go, and probably none of us will escape exposure to this virus. Some of us will not know we were exposed because we won't get sick from it. And hopefully that'll apply to most of us who are vaccinated. So that's why the call for we must flatten the curve. Here we are again, wave 4, we are right here. And the question is, in the next month, will we do like Saskatchewan and Alberta with this kind of a climb and everything out of control within 1 month by the end of October, or will we have this kind of a curve, which will be much flatter, which may last longer, but will not overwhelm our healthcare system? We have evidence that we can flatten the curve, indirect evidence by this data showing that the vast majority of people who are now being hospitalized with severe COVID-19, this is in Winnipeg, the vast majority of people have had no immunization. These dark bars or the orange bars were immunized too late, have had immunization recently, but not fully immunized. So if you add the black, the green, and the orange together, those are all people who are not fully immunized. And almost all the cases now ending up in intensive care units at death's door, literally very, very sick, are young and older people. In fact, even children are going to get into trouble, and children who can't be vaccinated right now are going to get into trouble. And the only way we can really protect them is by the 12-year-olds and older around these younger children all being vaccinated, so we can protect our younger ones. So Canada has agreements for 8 different vaccines, but right now we're really only administering 3 and primarily 2 vaccines. Right now we're primarily administering the Pfizer and the Moderna mRNA vaccines. It turns out that vaccine technology is one of the best vaccine platforms we have ever had. It's one of the safest vaccine platforms, combined with the most effective vaccines we've ever had. Live virus vaccines were, before mRNA vaccines, the most effective vaccines and they still are among the most effective vaccines we have, but live virus vaccines can cause much more severe reactions more frequently than mRNA vaccines, because live virus vaccines like the measles vaccine or the yellow fever vaccine are made from the live virus, and so they can sometimes cause pretty severe side effects. Very rare, but that can happen with live virus vaccines. That does not happen with mRNA vaccines, because mRNA is not a live virus at all. The AstraZeneca vaccine, we have less of it right now, and it's being administered less so at the moment, because it's not quite as effective as the mRNA vaccines, and its side effects, albeit rare, are still more common than the side effects would appear that we're seeing with the Pfizer and Moderna vaccine. So right now, the best vaccines, when you combine side effects with effectiveness, appear to be the Pfizer and the Moderna vaccines, then you really can't differentiate between the two. The two mRNA vaccines are considered equivalent to the point where you can receive, your first dose of one and your second dose of the other mRNA vaccine, and that's not a problem at all. So the big question is, how effective are these vaccines, especially against the variant strains? So as you can see, the mRNA vaccines are more than 95% effective against the old coronavirus, non-variant corona from a year ago. But even against the variant strains, the Alpha strain from the UK, the Beta strain from South Africa, and the Gamma strain from Brazil, 85% effective. But most importantly, because the strain we're most worried about is the Delta strain from India, the mRNA vaccines are still 85 to 95% effective, highly effective. So we have not lost vaccine effectiveness with these variant strains so far, or not appreciably. We've gone from over 95% down to 85 to 95. That's still among the most effective vaccines we've ever had. Any vaccine that's over 80% effective is among the most effective vaccines we've ever had for any disease, to be honest. The AstraZeneca vaccine, you'll see, not quite as strong or effective. This is, by the way, preventing hospitalization and death. So this is not the effectiveness in preventing COVID infection, but in preventing COVID infection severe enough to land you in hospital, or as an outcome, the worst possible outcome of death. AstraZeneca, less effective of the non-variant strains, but still over 90%, and still very effective against the Alpha strain, much less effective, as you can see, against the Beta and Gamma strains. But Beta and Gamma strains are not spreading right now, and they're not a major concern. But again, against the Delta strain, if you were immunized with AstraZeneca, you still have pretty strong protection against the Delta strain of 70 to 90% against the severe effects of COVID-19. So the bottom line is these vaccines are, and I see questions popping up, and I'm going to answer several of these questions shortly. So I'll let you, Tiffany, monitor the questions to figure out which ones I don't answer by the end of my talk. But the bottom line is, here are the facts. These vaccines are highly effective, even against variant strains, especially against the Delta strain. mRNA is not going to mess with our DNA. It's not going to cause weird genetic stuff in our bodies, and we don't have to worry about that. In fact, mRNA doesn't live in our body for very long. The mRNA molecules that are injected in us with the COVID vaccine, they only live for about a week or so, and then they get destroyed by our cells after they have made the proteins that need to be made for us to generate a strong immune protective reaction against the COVID-19 virus. So mRNA is not a live virus at all. So you cannot get COVID-19 from any of the COVID vaccines, because none of them are live virus vaccines. These vaccines, though, are only going to protect us against COVID-19. They do not protect us from other bacteria or viruses. For example, they don't protect us against influenza. So you still need to get your flu shot this year. Vaccines are free for everyone in Manitoba. And again, 2 doses are required of the AstraZeneca or the mRNA vaccines. But the bottom line is these vaccines work and they are safe. I'll talk a bit more about safety shortly. And really, anyone 12 years or older can receive a COVID-19 vaccine. The vaccines, again, are available to anyone and everyone, regardless of immigration status, and are free, regardless of immigration status. The first dose, again, anyone 12 years and above can receive a first dose Pfizer or Moderna. And the AstraZeneca age limit is somewhat older because younger people had more issues with AstraZeneca vaccine as far as side effects. But really right now, the AstraZeneca vaccine availability is very low, and most COVID vaccines being given at the moment are Pfizer or Moderna. As I said earlier, 5 to 11-year-olds, probably we won't have access it'll probably be lower doses, their vaccines, than we're giving adults, and we probably won't be able to roll out immunization for children until December is what we're hoping right now. But again, stay tuned. Everything can change. Second doses, again, it's okay if you received AstraZeneca as your first dose to get an mRNA vaccine as your second dose. In fact, a report in the New England Journal of Medicine that just came out, I'm just looking at it now, September 16th, so a very, very recent New England Journal article looking at people's immune response who received AstraZeneca as their first dose, followed by mRNA vaccine as their second dose, saw actually a stronger immune response than receiving 2 AstraZeneca doses. The AstraZeneca 2 doses still had a strong immune response with the booster dose, but the mRNA boosted it even higher. And some authorities are even suggesting if you got 2 AstraZeneca doses, it wouldn't hurt, although this isn't official recommendation yet in Manitoba, unless you're traveling overseas and you need that mRNA booster to enter another country, you will get a really strong booster response with the mRNA vaccine following 1 or 2 injections of AstraZeneca. And the mRNA vaccines are completely interchangeable. We're now talking about third doses. Probably most of us will be getting a third dose before the end of winter eventually, but for now, there isn't a lot of data suggesting we need third doses quite yet, at least most of us who have a normal immune system, who got a strong kind of immune response to 2 doses. We might not need a booster dose until a few months from now, but the exception for now being that people whose immune system is weak, people who have moderate to severe immune system compromise due to an underlying medical condition or due to chemotherapies or treatments that they may be receiving, might not have mounted a strong enough immune response with 2 doses, and now they're being offered a third dose. As I alluded to, people traveling internationally who received the AstraZeneca followed by an mRNA booster, there are a lot of people who did that, who got AstraZeneca for their first dose. AstraZeneca was not available for their second dose, and they got an mRNA booster, and now they can't travel because they only had 1 mRNA dose. They need a second mRNA a booster, which is essentially a third dose of vaccine to travel, to enter certain countries. People in that position can receive that third booster dose. And then international visitors or immigrants in Canada who received 1 or 2 doses of a COVID vaccine not currently approved by Health Canada, they can receive 1 dose of an mRNA vaccine on top of that 1 or 2 doses of COVID vaccines not currently approved. They can receive 1 dose of mRNA vaccine here in Manitoba, in Canada, and then they'll be considered fully immunized at that point. And then also now, because we've seen outbreaks emerging in First Nations community personal care homes specifically right now, could be the Delta variant starting to spread there, that residents and staff of personal care homes in First Nations communities are now being offered third doses. And we might be looking at widening that to all personal care homes in the province, residents and staff, possibly sometime in October, might also be recommended to look at getting a third booster dose. The super sites in these 8 locations, the Winnipeg Convention Center and in Brandon, Selkirk, Morden, Dawson, Steinbach, Gimli, and Thompson are still open. Not sure how long they will remain open as fewer and fewer people make use of the vaccination super sites. They may close over time unless we see a resurgence in interest in vaccines. And maybe when the booster doses are more widely recommended, we'll have maybe a need for the super sites again. But regardless of the super sites, one needs to keep checking online for pop-up clinics. There are pop-up clinics all over the place. I know the University of Manitoba has done several clinics for students and staff at the university, for example, and other campuses. Red River College has done the same thing. So again, the website you see here is where you would check for information in your neighborhood around where pop-up clinics are happening and whether the super sites are still open or not. But essentially, all persons willing to receive a COVID vaccine should be able to receive a COVID vaccine, including those who are pregnant and or breastfeeding, including those who are immune compromised, who are now being recommended a third booster dose, and even including those who have had previous severe allergic reactions or blood clots, but they should consult with their doctor first. But they are all eligible to receive the vaccine. Many pregnant women have received the COVID vaccine during this pandemic and have done well. And so that I think answers one of the questions I saw scrolling by in the chat. Those who have, we can't mix the COVID vaccine with other vaccines, partly because we want to make sure that if you're having a side effect after vaccines, we know whether it was the COVID-19 vaccine that caused a side effect or not. So we can't give other vaccines at the same time as the COVID vaccine. We would rather, after you receive the COVID vaccine, you wait 1 month, 28 days before receiving another vaccine. And if you received another vaccine like the flu shot this fall, we want you to wait 2 weeks or 14 days after the influenza vaccine before getting a COVID-19 vaccine dose. Again, just to separate out the vaccines so we don't get confused around any side effects happening. Even those who have had a severe allergic reaction to a COVID-19 vaccine have been and may be able to receive another dose under the supervision of an allergy specialist. Many people, several people who've had severe allergic reactions to the first dose of the COVID-19 vaccine, who decided to take a second dose under the supervision of an allergy specialist, all of them who decided to take a second dose have successfully received their second dose under protocols that are well designed to prevent another severe allergic reaction. But it's done under supervision of an allergist in an allergy clinic, where all the equipment is there in case you have a severe reaction. But really that hasn't happened. The second severe reaction has not happened under proper protocols. So side effects are common that are not severe side effects. 25 to 60% of people actually may get mild side effects. I'm one of those 25 to 60%. I got pain at my injection site both times, my first and second dose. I felt a little feverish both times. I felt achy both times, and I slept most of the next day, both times, with quite a bit of fatigue, but it only lasted a day. And I knew that would happen because in the past, I react to vaccines. My immune system somehow reacts very strongly to vaccines. That's not necessarily a bad thing. That means my immune system is working hard to give me immunity. And I got my COVID vaccines on a Friday, so that knowing that if I had a side effect, I could sort of weather it over the weekend and be back to work on Monday, which is exactly what happened. Rare side effects, I've already mentioned an allergic reaction occurs rarely. We're talking about levels of 1 in a million, very rarely. Some people who have allergies might be asked to stay for 30 minutes after their COVID immunization, just to make sure that they don't have an allergic reaction. But most people only need observation for 15 minutes after their COVID vaccine. And again, if you've had an allergic reaction to a COVID vaccine dose, it doesn't mean that you can't get a booster dose under allergy specialist supervision. You can get another dose safely. Another rare side effect you've heard of, blood clotting with the AstraZeneca vaccine, is probably why the AstraZeneca vaccine has kind of fallen out of favor somewhat because of the blood clotting happening in about 1 in 50,000 to 1 in 100,000 doses, mostly in younger, mostly in younger women that sort of put a bit of a brakes on the AstraZeneca vaccine. But as it turned out, the COVID infection itself causes life-threatening blood clots in about 1 in 10,000 people, or 10 times higher than the vaccine. So we don't want to ignore this side effect with AstraZeneca vaccine. It's manageable, it's treatable once it's detected, and it presents, with headache or seizures or difficulty moving a part of your body, difficulty speaking, which is really a sign of stroke happening from the blood clot in your brain. So it sounds horrible, but it's completely reversible and treatable. 100% when it's detected early. Whereas the same effect when this occurs with COVID infection, it's not so easily treatable. Many young people in their 40s with COVID infection, about 1 in 10,000, have had serious strokes and have not recovered from those strokes because it's much harder to treat the blood clots when you're infected with the COVID virus, whereas as a side effect of the vaccine, it's very treatable. Similarly, another rare side effect happening in about the same number, 1 in 50,000 to 1 in 100,000 doses, mostly in younger men, is an inflammation of the heart, also known as myocarditis or pericarditis, occurring with the mRNA vaccines only, the Pfizer and the Moderna vaccines. That turns out to be a relatively mild and self-limited, all sounds horrible, heart inflammation, but it turns out that hospitalization is rarely required. And even when it is required, complete recovery occurs. And this side effect is generally really not life-threatening. It's worrisome, but it's completely reversible and manageable. Again, myocarditis caused by COVID infection is 10 times higher than this, about 1 in 5,000 to 1 in 10,000. So you're much more likely to get a severe heart inflammation from a COVID virus infection that is not so manageable and not so recoverable than you will as a side effect from any of the vaccines. So this question I've already addressed and came up. What if I received AstraZeneca as my first dose and I can't find AstraZeneca as my second dose? You can certainly wait. The good period of time to wait to get a second dose of AstraZeneca is about 12 weeks because you get a stronger immune response with a second AstraZeneca dose 12 to 16 weeks after the first dose. But really right now, if you can't find AstraZeneca booster dose, as long as it's been 8 weeks since your AstraZeneca dose, you can get your second booster dose with Pfizer or Moderna mRNA vaccine. And as I said, recent data that's been recently published shows that that might actually give you a stronger booster response anyways. And so not a bad idea to receive an mRNA booster after your AstraZeneca initial dose. And again, what if you received, I've already addressed this, a non-Health Canada approved COVID vaccine? Your options, again, if you received 1 or 2 doses of an unapproved vaccine, you just need 1 mRNA vaccine dose to be considered fully immunized in Canada. If you received 3 doses of an unapproved vaccine outside of Canada, in Manitoba and in Canada, actually, you're actually considered immune at this point with no further doses recommended or needed. What about the flu shot? It's still, as I said, recommended for this winter, but you have to wait 14 days after your flu shot before you can get any COVID vaccine booster or initial dose. And similarly, if you've received the COVID vaccine dose, you need to wait a month or 28 days after the COVID vaccine before getting any other immunizations, including your influenza vaccine. So these vaccines need to be separated. They can't be given together at the moment. What do you do after you've been vaccinated? The same rules apply. Hand hygiene, physical distancing, stay home, please, if you're sick, limit your social contacts. If you don't have paid sick leave, advocate aggressively for that, your union or whatever means you have. We are in public health more and more strongly advocating for those kinds of policies so you can afford to stay home when you're sick. Wear a mask, limit your travel, all those things apply even if you've been vaccinated, even if you have more access to different venues if you're fully vaccinated, it's still important to be prudent. Again, I'll just end in a couple of minutes, but this is a slide I showed several months ago, and the answer is still the same. If you're eligible to be immunized, either for a third booster dose or for any dose if you haven't been immunized yet, the first vaccine available to you at a pop-up clinic, at your workplace, at wherever it is, at a super site, that's the best vaccine for you. And right now, it's most likely going to be a Pfizer or a Moderna vaccine, mRNA vaccine. And again, there are lots of locations, no excuses now where you can't get the vaccine. There are many places where you can get the vaccine. All vaccines that are approved for use are effective in preventing you from getting COVID-19, and especially effective, like over 90% effective, in reducing the seriousness of your illness, such that you won't be hospitalized and you won't end up in ICU and you won't end up dying, even if you get, and it's not even if you get, it's when you get infected with COVID-19, because very few, if any of us, are going to escape exposure to this virus. It's just going to be, Delta virus is so easily spreadable that once it's here, it'll spread to almost everyone. And again, being immunized with one type of vaccine now will not prevent you from getting a different type of vaccine in the future. So for third doses, and even if we need annual booster doses, it probably with time won't matter what type of vaccine, whether it's mRNA or a non-mRNA vaccine. We know this from decades of experience with vaccines. We have an oral live virus polio vaccine, and we have an injectable killed polio virus vaccine, and they both work effectively, and they can both be interchanged, one used after the other, and we've known that for decades. The immunization card should not be difficult for you to get. If you are having trouble getting your QR code or immunization card and you can't get it through the online application, which is relatively user-friendly, but if you're having trouble with that, call this number, 1-844-MAN-BACK, 626-8222. Call this number. They are very friendly. I'm told they're very helpful, and they will do what they can. For example, if you're an immigrant who's received 3 non-approved COVID vaccines outside of Canada, and you're now considered fully immune, you should be eligible for a vaccination card. But because you're not in the system, you might have to show that proof of vaccination, and before you can get a vaccination card, call this number. They should be able to help you. You do not need a Manitoba health card to get a COVID immunization card. And again, once you have a COVID immunization QR code, you don't actually need the card. If for some reason the card takes several weeks to be mailed to you, you can download the digital immunization card onto your mobile phone. Most of us, as all you need is a mobile phone, you can, I myself don't have to carry my card because I've got my QR code on my phone. I've used it several times and it works just quite fine. And then I'll just quickly show you these slides as I conclude now. There is, for those of you who are dealing with populations where English and French is not a first language, there continues to be lots of sites with multilingual COVID-19 basic information as well as COVID-19 vaccine information. Some sites include on Manitoba Health website, this site here, COVID-19 facts, as well as COVID-19 vaccine information in several languages. And also our local language access interpreter services have over 200 languages that can be reached if you need help in communicating with the client. And Health Canada has what you need to know about COVID-19 vaccines in several languages at this website. And actually, Toronto Public Health has some very good COVID vaccine fact sheets in multiple languages that you can see here. These slides will be available to you. Tiffany, I think, will be making sure that these slides are sent to you. So you will have access to these slides and these links that you can click directly on the slide if you're looking at the slides at your computer. And HealthLinks is also a local resource that can always help. They also have access to the 200+ language interpreters should they need help over the phone to help you with your questions around COVID-19 or COVID-19 vaccine. So that is all I had to say. I think I've left a good 15 minutes for questions, and I will hand it back over to Tiffany if she would like to moderate the questions.
So Dr. Plourde, I'm going to put this on the share screen. We try our best to capture all the questions and comments from the chat box area. So these are the questions. Can you see it on the screen, Dr. Plourde?
Yes. Okay. I'll try to go through them one by one, and if I can't answer them, I won't answer them. We are seeing a province post numbers of individuals who are partially or fully vaccinated, but are still diagnosed with COVID. Is there data you can share about these cases? When were they vaccinated? So somebody who's not vaccinated is obviously not vaccinated, and partially vaccinated, by definition, what that means is either they've only received one dose or they have received the second dose, but 2 weeks haven't elapsed yet. So they're not considered fully immune with the full kind of immune response. These people are more likely to get sick with COVID infection and more severe infection, especially hospitalized and or in ICU. I can't give you more specifics than that. It doesn't matter which vaccine, to be honest. mRNA and AstraZeneca, as I showed you, are practically equally protective, and so it doesn't. And we don't have those numbers separating out which vaccine that people received. Status of AstraZeneca, I think I mentioned that AstraZeneca is in far smaller quantities right now than the mRNA vaccines in stock. And AstraZeneca has fallen a bit out of favor, I have a feeling, partly because of the negative publicity around the blood clots, and also the effectiveness of it being a little less against the Delta strain than the mRNA vaccines. And also the data now showing that an mRNA vaccine following AstraZeneca dose actually gives you a stronger boost immune response. So for that, all those reasons, I think that mRNA vaccines are going to remain more popular at the current time for good reason. Again, vaccines are fine in pregnancy. I think I mentioned that on one of my slides. These vaccines are effective and safe in pregnancy. I don't think I need to say anything else about that. As Pfizer is approved for under 12, like it is in the US, can we prioritize the kids and the booster for third shots for those who need? So it'll probably be different vaccines. As I said, the vaccines for 5 to 11-year-olds will likely be a smaller dose than what we're doing for adults. And so we won't have a competition. Children will hopefully not be competing for the same vaccine, even though they're both Pfizer vaccines. The adult vaccine will be different likely than the child vaccine. So we won't be competing, third shot boosters against children vaccines. And we have to figure out how to deliver the booster vaccines. Maybe super sites and pop-up clinics will still be the way to go, in addition to pharmacies and maybe doctors' offices, which is difficult with Pfizer, which needs that minus 80-degree temperature. So that's what makes Pfizer harder to administer. And for kids, I'm not involved in the logistics, but for kids, obviously schools are where children are a captive audience, and we have a long history of working immunizations in schools, with getting parental consent and getting children immunized in large numbers in schools. The problem will be how feasible that is with the Pfizer vaccine if the minus 80 temperature requirement becomes a challenge. But I'm hearing now that there's been some relaxation on that temperature requirement, making Pfizer easier to use, for example, in a school setting. Yeah, good question. How can we effectively reach those who are on the fence about vaccination? I honestly don't have the magic solution. I'm hearing, President Biden implore people to get vaccinated. I'm hearing, premiers and our prime minister imploring people. For me, it's a no-brainer without really being insulting. For me, it's kind of, the data is so overwhelmingly obvious that these vaccines work. They're safe. Delta strain is dangerous, not to be messed around with. All of us are going to be exposed to the Delta strain. It'll be very hard for us to escape the Delta strain. It might even be airborne transmitted, which was what's making it so wildly spreadable. Our children are going to get the Delta strain, and they're going to spread it in schools like crazy, and they're going to bring it home. We're all going to be exposed, and those of us who are not immunized are really taking a chance, literally playing Russian roulette with more than one bullet in the chamber. and sadly, and we just saw in the news last night, somebody from Alberta coming out of the intensive care unit. Luckily, he survived, a young gentleman who was on the fence, who is saying, for God's sake, get vaccinated. So we need more people like that to just implore us to get vaccinated. How do you know if the vaccine has actually worked without testing for antibodies? Testing for antibodies is really not terribly reliable, to be honest. Antibodies are just one little component of your immune system. So if you have a high level of antibodies, okay, you might have some reassurance, but that doesn't tell you whether your other half of your immune system, cell-mediated immune response, was also equally triggered. So you don't know that the vaccine has worked for yourself for sure, unless, I would say, if you've had significant, like if you had strong side effects like me, I'm sure the vaccine worked with me. I had lymph node swelling. My immune system was churning. You know, the opposite doesn't true. If you had no side effects, it doesn't mean the vaccine didn't work. But if you had robust side effects to the vaccine, you're pretty certain that the vaccine has worked and you've mounted a pretty robust immune response. And how do you know? Well, you know, because over 90 to 95% of people in all the studies that have been done have had a very robust immune response and also have been protected against severe consequences of this virus. And that's the only way that you know it indirectly from the data that's out there. An approach to those people who are holding out, okay, they just don't know the long-term effects of the vaccine. I think that argument doesn't hold so much anymore. We could say that during the first month or two of immunization, but having had now over a year of COVID vaccine immunizations under our belt, and the most intense follow-up we've ever had for any vaccines with COVID-19 vaccines, knowing that beyond 12 months, long-term effects of the vaccines are virtually non-existent, the chances that we're going to discover something 5 or 10 years from now related to COVID-19 vaccines is next to nil. That's just never been shown with any vaccines that we've used since the 1950s. And so, and you'll say, oh, but what about mRNA vaccines? They're new. They're not new. mRNA vaccines have been around for 20 years. Research on mRNA vaccines goes back 20 years, back to 2003 with the first SARS virus. They were already researching mRNA vaccines in animals as well, even as in humans, for different diseases and different viruses. So why do we all of a sudden have an mRNA vaccine that's been marketed? Because we've never had a pandemic that's threatening the life of so many people on the planet. And so we finally got a reason to fund and to work cooperatively internationally to get an mRNA vaccine produced and on the market because of an urgent, desperate need to do so. I'm not worried about long-term effects, to be honest. Define a strong immune response. If somebody did not, yeah, I've already answered that. I'm not saying that if you didn't have an immune response, you didn't have, if you didn't have side effects, you didn't have an immune response. There's lots of examples of people in the studies and the research who had minimal to no side effects, who got a strong, very strong immune response. But what I am saying is, if you did get strong side effects, you can almost be certain that you got a pretty robust, strong immune response. And I define that as an immune response that is giving you 90 to 95% protection against hospitalization, intensive care unit admission, or death from this virus. So very, very strong protection against the severe outcomes. Getting the flu vaccine early in the season so that we don't interfere. Yes. And so the flu vaccine is going to begin to be available very soon for healthcare providers. I think in my workplace in a week or two, I have booked on my calendar an opportunity to get the influenza vaccine. So yeah, that's the time to get it, because I won't be eligible for a third booster dose of COVID vaccine, probably not till, late October or maybe November, or who knows when. So I'm getting my influenza vaccine sooner rather than later. So I would agree with that comment. Official policy on third doses, a recommendation, an eventual requirement, or we do not know it yet. So I'm not 100% sure how it's worded online. I think right now it's more of a recommendation and not a requirement. I don't think we're looking at a requirement yet. We're still considering people with 2 doses fully immunized. Only time will tell. We'll have to see what the 4th wave shows, what we are in store for this winter, as to whether or not people will have to get a 3rd booster dose. But that's, I'm suspecting that that's going to be probably not till next year, maybe next winter. We'll have to get a 3rd booster dose, but probably not for this winter. I think most of us will be protected with the 2 doses we have for this winter, and that's all that will be actually required. How do we do a massive blitz and have it available everywhere? Primary care clinics, make sure it is offered to all with each visit. Again, the primary care clinic challenge has been cold chain and the extreme negative temperature refrigeration that's been required for both of these vaccines, less so for the Moderna. So a bit easier for the Moderna, but not as easy for the Pfizer, to have the vaccine distributed to a whole bunch of sites without having much more wastage. There's already almost a 1% wastage with the Pfizer vaccine, even when you administer it in massive amounts, 10,000 people a day in super site clinics. If we were to distribute that many Pfizer vaccines to many clinics, the wastage would probably be far higher than 1%. So I guess the logistics people have to take that into consideration as well. Will staff members in personal care homes be offered? Yes, I mentioned that. I don't know for sure, but I mentioned that in one of my slides, that the hope is that sometime in October, once the First Nations communities have had the personal care home staff and residents have had this staff and residents have been immunized, they will probably be expanding that to all personal care homes in the province, staff and residents. So again, stay tuned. I am listening carefully to Dr. Joss Reimer and just going by her recommendations, and the hope is that that recommendation will come out sometime in October. Antibody-dependent enhancement of the mRNA vaccine. We are only 3 minutes away from 10:30. That would take an hour to explain. The bottom line is it's not an issue. The bottom line is the viruses that they've used and the vaccines they've used to compare this to are completely different mechanisms in vivo, in the humans or animals, where this reaction can potentially occur. That basically means, an mRNA vaccine creating an enhanced severe reaction and booster dosing. We're basically not seeing it. It's non-existent, and because the mechanism of action of the mRNA vaccine is so different, it turns out that this is not an issue. And I'm not a molecular biologist, but that's my understanding from the literature that I've been reading in the reputable peer-reviewed journals. Any rare reaction can lead to death. Any anaphylaxis, any severe myocarditis, any severe clot reaction can lead to death. So yes, there have been rare reactions leading to death, but that's extremely rare. Far, far rarer. Death due to COVID infection runs at about 3 to 5%. Death from the COVID vaccine is virtually non-existent. We're talking about case reports. We're talking about reports that are so sensational they end up in the media, or they end up being published because they're so rare. For 3rd doses, do you need to have imminent travel plans? Yes. If your reason for getting a 3rd dose is because you got an AstraZeneca followed by an mRNA and you need a 2nd mRNA, you have to show proof of your travel plans. As far as I know, that's my understanding. List of ingredients. That's easily findable online, the list of ingredients in a vaccine. And that's a good question, actually, because if you've had an allergic reaction to one of the vaccines, say the mRNA or the AstraZeneca vaccine, you can often get, your reaction is likely not to the mRNA, but to another ingredient in the vaccine. that is not present in one of the other vaccines. So people have had, a first dose, and that's how we've managed to give people booster doses successfully under allergy clinic supervision. Is the first dose they got was maybe Pfizer and they got a severe allergic reaction. For the second dose, they were given the Moderna because they've likely reacted to something else, an ingredient in the Pfizer vaccine that's not present in the mRNA vaccine, and they received the second vaccine with no problem at all. If you receive 2 doses of AstraZeneca, are you eligible for yes, as long as you can prove your international travel. I had to take a call and missed the 3rd dose approval. CDC is recommending 3rd dose for those 65 and over with no restrictions. Will Canada follow? Probably eventually, but the data is weak on that. 65 and over, so not everybody is on board, and I know Health Canada, Public Health Agency of Canada are probably looking at that data still, and I can't say when Canada will follow, but probably booster dosing will eventually follow in time. And who will be most eligible? PCH residents and staff, for example, healthcare workers, and probably older people, like we did in the spring, will be most initially eligible for a 3rd booster dose. If you got a card after the 2nd dose, no, you won't need a card after the 3rd dose. What'll probably happen is your QR code will access the information as to your vaccination status. Are you fully immunized? And if and when having a 3rd dose is now mandated and required, maybe next winter, as I was alluding to, then the system will change so that in order for your QR code to record you as fully immunized, you'll have to have had that 3rd dose recognized by your card. As far as I know, you shouldn't need new cards. The electronic system is such that your card should be good indefinitely. How long are you infectious with the symptomatic COVID virus? It depends, but viral loads, and it can be for several days. That's why we do the isolation for 10 days from onset of symptoms, because you can be infectious out to 10 days with symptomatic COVID. And with Delta, your viral load is excessively high. That's probably why, another reason why Delta is so easily transmissible. Your viral loads are excessively high. It might be airborne transmitted because the viral loads are so excessively high. And who knows if you might be infectious for a longer period of time with the Delta virus. Is getting COVID from someone who is not vaccinated? No, getting COVID is the virus in somebody who's infecting somebody who's vaccinated or not vaccinated. If it's a Delta strain, is the same Delta strain infecting both people. But the person who's vaccinated is less likely to get severely ill. But if they spread that COVID strain to you and you're not vaccinated, you're susceptible to the more severe effects of that Delta strain because you're not vaccinated. Wow, I hope that answered all the questions.
Thank you so much, Dr. Plourde. I noticed that there are quite another big list of the question and comment on the chat. Unfortunately, we adjusted that because of the time constraint, limited time, we are unable to take care and address all the question. If anyone want to follow up with us, you could send us the email, then I could pass on to Dr. Plourde for more information to provide to you later. So this session have been recorded, and I will send you the record session link and also with the slide to share with you. Once again, thank you so much, Dr. Plourde, for your presentation. It's really, really informative. We learned a lot from you. And also thank you for all the participants. Will be so engaging to put up all your comment and question on the chat area. So we will see you at the next public presentation on October 14th. So we will send out the post already, so you could please register. Thank you so much. Have a good day.
Very welcome. It was a pleasure.